So, good afternoon, everyone, and welcome to today's event. I'm Deerin, Director of Enlighten. Our guest today is Jeane Freeman. Jeane has had a long and successful leadership career in the fields of health and social justice, latterly as Cabinet Secretary for Health and Sport in the Scottish Government before she stood down from Holyrood in 2021. Her time in government was particularly active, as well as helping lead the country's response to COVID. She commissioned the Feely Report into social care and was involved in the rollout of hospital at home. I suppose by now we're all familiar with the facts, and they are alarming ones. Scotland's life expectancy has been falling, waiting lists are growing, the population is ageing, social care is in crisis, and the move to a prevention agenda has largely yet to be delivered. In a period of shrinking revenue, what can be done to rescue our beleaguered NHS? And how do we develop long-term multidisciplinary reform, but with cross-party buy-in? I think that's one of the key things we'll talk about today, about how we actually get this important stuff done in quite a challenging political climate. So today, we'll ask Jeane to reflect on her own time in government, where she was successful, perhaps less successful, the lessons she learned over the course of her career, and what she thinks needs to be done now to ensure the survival of our health and care systems, which is maybe not overstating it these days. I should say this is part of our NHS 2048 programme, which you can, if you go on the Enlighten website, you'll find lots and lots of articles and papers and other events. That's how you like to spend your time. And as ever, we'll take your questions in the second half of this hour. So please do post them on the Zoom chat function, and we'll take the best ones, as many as we can, before we finish. So Jeane, I suppose I'd like to start with COVID, something that impacted all of our lives significantly, an utterly unique experience for us all, very challenging, upsetting, changed the way that we lived and maybe the way that we still live in all sorts of ways. But you were at the heart of the government's response. And I just wonder if you could reflect a bit on what the experience was like from your perspective, being at the heart of such a massive crisis for the country, having to take decisions that made a huge impact on people's lives. And you know how you coped with that, both as a human being and as a minister, I suppose.
So hi, Chris, and hello to everyone else who's zoomed in. That's a huge question, if I'm honest, and it would probably take us the whole hour. But I think briefly, let me just say this: if we had to have a pandemic, I would have wanted to be the health secretary at that time, which might sound a bit odd, but I would have wanted to be at the heart of that decision making. It underlined for me that certainly during COVID, there was no such thing as a risk-free decision. It was a series of decisions that considered levels of risk, and with the overall objective of trying to minimise the number of people in Scotland who were harmed by the virus or killed by the virus. I was struck all the time about how marvellous our NHS was, how well it pivoted to focus hard on doing that at every level, from porters and housekeepers through to senior consultants and nurses, bringing in medical students in their final year, nursing students in their final year to complete the workforce was a significant step. Of course, there is also hard decisions and hard memories in that, about the people who died, about what happened in our residential social care and in home social care, and the lessons that I think we can draw from all of that. It was a time where what I knew about the virus and how it operated, how it transmitted in the morning on my way into government would have changed significantly by lunchtime, changed again by the evening, simply because it was a virus unknown to our clinical experts, and they were, in an iterative way, updating their understanding and knowledge, and therefore their advice all the time. The other thing I think I learned from it was the importance of quality communication with the public. And by quality, I mean telling people what we know, also telling them what we don't know, and explaining why we're making the decisions we're making and the significant things we're asking them to do. So I don't regret having been part of all of that. It was a huge privilege. I regret the fact that because of that, there were changes to our NHS that there was no time for me to pursue. And I do regret that the work that I commissioned in the Feely report, which arose out of my experience of social care across the country, partly through COVID, but also in my previous role when I had responsibility for adult disability and child disability, showed me that the system was not equitable across Scotland and we needed to improve that. So commissioning the Feely report was, I think, an important thing that I did, and I regret that we're not actually seeing its implementation at this point.
I read Nicola Sturgeon's memoir, and one of its most powerful parts, in fact, a number of powerful parts, affecting parts, was her coping with being a leader at a time of such a national crisis, an epidemic, large-scale deaths, severe illness, people being separated from loved ones at key points. How did you cope as a person as much as a minister? I'm sure you threw yourself into the work and just kind of put your head down and got on with it. But, it must have been a traumatic experience as well as a rewarding one in some senses, because you were doing things that were helping people.
Yes, I think I coped and to an extent still do, because I have the UK COVID inquiry coming up, the Scottish COVID inquiry, both of which are important, but both of which don't allow you to put the experience behind you and reflect on it fully, because you're back living it in responding to the inquiry's demands, reasonable, justifiable demands. But I think I coped with it by, if you like, boxing how I was feeling into one place and focusing on what I needed to do. Now, inevitably, there are points in that where something relatively small happens and you react emotionally disproportionately greater than the thing that has happened would warrant. So that's everything else coming to the fore. I think I had sufficient self-awareness to understand that that's what was happening, but I also felt a huge responsibility that, in a sense, this wasn't about me. This was about how well I could do my job and how well I could support the health service and social care, also recognising that, in a sense, no matter what we did, if you ask people to isolate themselves from their daily lives, whether that's their work, going outside, their family, going to the shops, going out for a drink, going to the restaurant, seeing friends, you're asking them to stop doing all of that. And that is really hard to do. And whilst our staff in the NHS are highly skilled, very professional, hugely committed, and if we saw it nowhere else, we saw it then, they have family and friends too. So they're going into work worrying about their relatives who may be ill or who may be vulnerable to being ill, and they're carrying that load. So if I was carrying a load, they were carrying a huge load compared to that, and they were in there every day doing that work. So yes, of course it was hard. Of course it was 7 days a week, long hours, all of that. But it was nowhere near as hard as people on the receiving end, either in our NHS or in our communities.
As you say, you've been dealing with the various inquiries into the COVID moment, if I can call it that. With the benefit of hindsight, and as you're preparing your evidence to go and speak at these things, when you look back at what the Scottish Government got right and what you might do differently now, could you talk a bit about those two sides of the equation?
I think our public communication we got right. I think by and large, the decisions we took were the right decisions. There is a debate around whether or not we took some of those decisions, for example, the first lockdown, quick enough. There are constraints on what the Scottish Government can do given the devolved reserved position in the UK, and in particular around access to financial resources. If you're going to lock down everything, you need to compensate. So there were restraints around some of that may have delayed or may be arguments for some of the delay. I think there is a debate to be had too around our children and young people. I know the inquiry just now at UK level is looking at the impact on young people. While all the time the decisions that were made were informed by expert advice, nonetheless, as politicians, we made the decisions. And perhaps we should have thought more about the impact of some of that. Not just on young people's education, but on mental health, some of which I think we're seeing the consequences of that now. And I think I'd probably argue that at the time, the need to make decisions and make them with the best information you had at the time as quickly as you could reasonably make them was paramount. I'm not sure that as we progressed through 2020, 21, and maybe beyond, that enough thought has been given to what has been the impact on the population, not just in health terms, where operations were delayed and cancelled and so on, but in terms of people's mental health, their sense of cohesion as part of a community, all of that, and whether or not government could have done more in thinking that through. I think those are reasonable and necessary discussions to have.
And obviously easier to do with hindsight when you're dealing with a fast-moving situation at the time.
Oh, everything is.
Doing the best you can, indeed. So I noticed today that the Scottish Social Attitudes Survey has looked back at the last quarter century, and it says that satisfaction with the NHS is at its lowest level in 25 years. In Scotland, it's just 22% at the moment. 2 in 3 people think standards have declined since the pandemic. We know that more people are going private for operations. How would you characterise the scale of the crisis facing the NHS and the danger to it over the medium to long term if we don't get reform right? Loss of public confidence, loss of public trust, people maybe bailing out of the system where they can afford it or borrowing to do that. Clinicians, real loss of confidence in the environment they're working in. So how would you characterise the scale of what we're facing?
So the first thing I'd do is I'd stop calling it a crisis, because I think that immediately lifts the ante and makes everyone think that it's on its knees. And I am always conscious of the healthcare worker getting up in the morning, going to their work and hearing on the news that where they are working is in crisis. I'm not sure that is overly helpful. That's not to diminish the seriousness of the situation. But I also think attitude surveys are really interesting. From the time many years ago, so what, 2000, 2002, when I was a special advisor working in health as well as other areas, I recall then that if you asked people, what do you think of our NHS? They'd tell you it was in trouble. If you then said, have you used it yourself or any member of your family? And they said yes, they would then tell you it was marvellous. So it is possible for people to hold 2 views at the same time, that their personal experience is excellent, but their view is that the system is in trouble. Now, that's not to diminish that view, but I think we need to be careful about considering that the whole thing is falling apart. I don't believe it is, but it is serious. And the seriousness of it is the need for reform. And that's reform in how our NHS is organised, how it's funded, how we manage competing pressures of huge amounts of healthcare innovation that has changed the face of treatment hugely in even the last 5 years, and how we align the reform we need in adult social care with the reform in healthcare. I don't think it is a question of money necessarily. I don't want everyone to rush off and say, former health secretary says the NHS doesn't need any more money. I'm not saying that. What I'm saying is it's about how we use the money. And I personally think, for example, that we have too many health boards in Scotland, that we have too many duplication of services essential to the running of an organisation, absolutely, like finance, HR, legal services, etc., IT, but we don't need to have it 14 times in our territorial boards. So I think there are ways of looking at how you reform within the NHS and how it is organised, structured and delivered that can release resource that you then use to the frontline service. And I do think there is, in addition, a need for a full conversation with our Royal Colleges, our Royal College of Physicians and Surgeons, our Royal College of Emergency Medicine, our Royal College of Nursing and BMA, frank cross-specialism discussion about what they think is a fair measure of how effective the work of their members is, that then informs the kind of measures that government asks them to demonstrate. And I think there is also value in a real conversation with those frontline individuals about what they think the service needs to deliver better, faster, not necessarily better care, because I think the quality of care is very high, but faster care, more accessible care, where that care is located. It doesn't all have to be hospital-based. And I'm minded, I think I told you this before, of an experience I had when I chaired the Golden Jubilee National Hospital. Very proud they are of what they call the door-to-balloon time for heart attacks. Basically, how quick do you get someone from the incident into the theatre to be fixed? Very proud of their time, wanting to stay number one in the UK. They were at that point. And actually, the person who came up with the idea about how to speed up the transfer of the patient from the ambulance arriving to the theatre were the Porter staff, because they saw it. So my point is, everyone involved in the NHS has good ideas about how to improve accessibility, speed, quality of care, and we have to ask them. I am a real stronger than ever believer that our NHS should be clinically led, and management's role is to enable that clinical leadership.
In terms of those conversations, there's also, I would suggest, a conversation to be had with the public, because as we see, it's one thing to talk about reform, but as soon as anyone tries to do it, the opposition politicians are going to wade in, whether it's a good idea or not, for political advantage. But also the public are very protective, maybe less protective than they used to be, but nevertheless understanding that the NHS is free at the point of need. But that actually it can't do everything, and the pressures on it are so great financially, patient numbers, etc. How do you have a kind of grown-up conversation with the public about this stuff so that you can actually get permission, if you like, to drive through some of these quite difficult reforms?
So I think the public are very protective of the idea of the NHS, of the idea of, as you say, care free at the point of need. They don't want to go back to the situation in the 30s where people didn't access care because they couldn't afford it. I think it's perfectly possible to do this. We've got more than one example. We've got the Professor Care work pre-2007, where town hall meetings were organised around the country that people went to, and they were facilitated, they were guided onto particular subject areas. It wasn't a free-for-all, but their views were listened to and heard and reflected to a degree in the report that he then produced. We've got experience that I led in the creation of Social Security Scotland with the experience panels. So that was ordinary people who had experience of a social security system telling us what was wrong with that experience, how they wanted to improve it, how it could be made better. So it's entirely possible to do this. Right now in 2025, with an election coming in 26, is probably not the ideal time, because that is exactly the point when political parties are beginning to line up their differing offers for the election and for the voter. But immediately after that election is the time. So the planning could be now. I don't think there's such a huge difference in view between some of our political parties about what needs to be done. And I think one of the things that the 26 election could be used for is for us as voters to make it crystal clear to all the political parties that we actually want them to do this seriously and not have squabbles about it. And that includes, how are you going to finally deliver the preventative agenda? Because all of us, elected politicians, have failed to do that up until now.
You touched on the point of politicians working together. I think that's something that you hear more and more, because you can't really do it as one party or one government. But you were Health Secretary. How did you find trying to put through reform or change and the response of the other parties? Was it a bruising experience? Did you find that some of your opponents were willing to work sensibly with you? How would you calculate the kind of challenges that you faced, positive versus negative?
So I didn't, with one or two exceptions, I didn't find it a bruising experience. I think to the wider public, I would say, don't judge how politicians work by what you see in the debating chamber, especially around First Minister's questions. So on those occasions, you know, there's a bit of point scoring going on. There's a bit of high horse being sat on. What I found was not across all the parties, but I found it perfectly possible to work with colleagues from other parties on issues such as MESH, for example, such as the issue in terms of Queen Elizabeth, the Queen Elizabeth University Hospital campus in Glasgow, or NHS Highland and the whistleblowers. I found it perfectly possible to work with colleagues in other parties, provided we agreed on the overall objective and were willing to compromise on the way there. I genuinely never cared who got the glory of it, as long as we got it sorted. Because at the end of the day, if you're the Health Secretary, your primary concern has to be, how do I make this better for fellow human beings, wherever they are, whether they work in the NHS, whether they receive care from it, whether they work in social care, or whether they require social care. It doesn't matter. So there's always consensus and compromise to be found. And you just have to put the effort in and work your way through that. So I think it is entirely possible, but it is a question of will.
Well, that's pleasing to hear, I think. Just to move on to social care, obviously, which was a major thing for you. And it's often said we can't fix the NHS until we fix social care. But despite the fact that 3/5 of us will be carers at some point, it doesn't seem to get the same attention, certainly from the electorate. And it does seem to be something that the politicians are struggling to get to grips with on both sides of the border, actually. So why do you think it's proving so hard to wrestle with what is, you know, a key obstacle to reforming the NHS in its entirety? Until we deal with social care, we can't deal with very much else. If people are in social care they're less likely to have to go into hospital, and they've got somewhere to go when they come out, so they're less likely to have to stay in hospital. But despite the debate that's run, despite the Feely report that you commissioned, we're still not really getting there. The SNP government's bill has been hollowed out, so that's not going to deliver what was hoped for. How do you see that situation?
So I completely agree that the priority given to adult social care is not as great as it needed to be. I think that was pretty evident during the COVID pandemic, consequently the commissioning of the Feely report. At the time of the Feely report, there was consensus on its conclusions, with one exception, and that was a concern from COSLA, which was legitimate, that if you took adult social care into a central body, that compromised key elements of adult social care, which local authorities had responsibility for, like housing, like social work. And there was a niggle on the part of local authorities, which I understood, that had been long-standing, actually, probably since the time of the creation of the Scottish Parliament, and that is that their authority and jurisdiction, if you like, would be hollowed out by centralisation. My view was, but just about everything else that was in that report, in fact, every other recommendation, COSLA were supportive of. So my view at the time was, like any negotiation, can we concentrate and agree on what we agree and how we're going to deliver that, and work our way through where the disagreement is and see how we can navigate a solution out of that. Now, I wasn't in government after May 21, so I don't know, and I will not comment on what then happened, because I don't know. But I think if we got there in the first place, we can get back there. And I think that is absolutely critical to do, because not only do we need to reform adult social care, we need to reform it in a way that what you receive is equitable across the country. We can't have good social care in one bit of Scotland and poor social care somewhere else. That's just not fair, and it's not right. At the same time, well, I think it is possible to go back to what was that consensus and work our way through it again. I do also think that the kinds of things the NHS is doing, like increasing the availability of hospital at home, increasing the number of procedures. This is where medical innovation and advancement comes in, can be day case as opposed to time in hospital. If you begin to put those pieces of the jigsaw together, you can see how we can improve access to healthcare, improvement in social care, and speed of response, which I think then means, I think people who are currently looking to the private sector are doing so not because they think that's necessarily what they want to do, but because they're in pain, their lives are diminished in various ways as a consequence of whatever the condition is, and they want it to end, and so they go to the private sector. I don't criticise that, I understand it, but it is a big signal to those of us who support a national health service and nationally available social care that we need to sort this out. Otherwise, we will begin to undermine the principles that inform the creation of both.
And the other key issue, I suppose, that is talked about all the time now is prevention, and moving care maybe out of secondary care into either the home or primary care, or just keeping people healthier for longer. I suppose, resources are tight, and the people working in the NHS and health in general are firefighting constantly and addressing illness in hospitals. How do you, and we've been talking about prevention for so long, and I'm not saying nothing has happened, but obviously we haven't made the strides that those who know about this stuff think that we should. What's your view of how we can actually finally begin to make proper progress, given our appalling national health record, if you like? How do we actually make that happen when you're trying to take money away, maybe from the NHS, which eats up a lot of public resource, and move it into community care or whatever it's going to be? So what would your view be on that?
So I think the important starting point is actually one of the things you said. We need to recognise some of the major preventative health measures that have been put in place, and smoking ban is an example of that. I think we also need to recognise that good public health is not exclusively the responsibility of our National Health Service. It is also, there are key economic elements in that. If people are living on very low incomes, it is very difficult to live healthily. But I think in terms of government, so economic growth and economic prosperity and equity of access to that prosperity is absolutely critical to good public health. And therefore it is an ask of that part of government as much as it is an ask of our health service. But I also think we need to ask people. I don't know, you're a young man, and many of our audience will be young, I'm sure. So I don't know if everybody remembers one of the early government ads about eating healthily, with the healthiest, fittest looking builder I have ever seen in my life wander down the street with not a bit of dust or cement or anything on him, using a banana as a telephone. And the intention was well-founded, it was sincere, but it would have zip impact on people about how you could possibly, on an extremely low budget, provide healthy, nutritious food for your family that they would then eat. So my view is, let's not devise healthy eating or other public health campaigns in government. Let's devise them with people who are in those situations, struggling to do the best they can. Let's ask them what they need to improve their situation, because they do want to improve it, and let that then inform what government does.
I suppose the other issue that comes up when we're talking about maybe moving resource from or towards a preventative agenda is that the incentives in the NHS aren't quite aligned with getting that done. And also that you do come across, if you do in most sectors, siloed thinking and policy around health, whether it's primary, secondary, third sector, social care. And there are a lot of voices protecting their own silos, including the Royal Colleges and the BMA, etc. Doctors will argue they need more money. Social care staff can earn more working in supermarkets than they can doing a job that's at the heart of a strong society. So I suppose it's natural to expect an element of certain groups to protect their own interests, but that probably has a detrimental impact on overall policy making.
It can do, and there are instances where you can see that it has done that. But I do believe it's not Pollyannish. This is decades of experience. I think if you get people in the room of conflicting self-interests, but ask them to answer the single question, they will work it through, because nobody really wants to be the person or the group that says, I don't agree with preventative healthcare because I want more money here. You don't want to be that person. So you have to find a way to reach that consensus. And I think it is possible. I think we have examples where it is possible. At the end of the day, all those Royal Colleges represent members who have dedicated years of study and their life to quality patient care in whatever form. And that's what you're honing in on. How can we do that better? And part of the way of doing it better is to actually be sending fewer patients to you. because they are living in a more healthy environment in terms of housing, the economy, and their own health. And therefore, some of the conditions that you are now dealing with are reduced. I genuinely think you can get them to a point where they start applying their intellect to resolving that situation. They have to trust that government means it and will then commit to delivering on what they suggest. And if the government believes they can't deliver on what's suggested, they have an equally frank and open conversation about why not.
So I've got one more question for now, and then I'd like to take questions and thoughts from the audience. So if you do have a question, please put it on the chat function. We can't not talk about technology. Regardless of what we're talking about, we always end up talking about technology. You know, and the Labour government at Westminster hasn't had its troubles to seek, but perhaps the minister who seems to have really hit the ground running is Wes Streeting, the English Health Secretary. The NHS app, which you know, seems to be getting bells and whistles added to it at a fast rate down south. We're obviously still some way away from being anywhere near the English level at the moment. We're talking about the end of the year for a pretty basic version that will only be available in North Lanarkshire, dealing with dermatology as far as I can see. But why have we fallen far behind, do you think, on something that is so obviously needs to happen and will make things easier in all sorts of ways, make things more efficient, give people hopefully a smoother relationship with when they're dealing with the health system? Why has this not been grabbed in Scotland in the way it seems to have been down south? And in other countries, I should say. So.
No, Chris, I can't answer that. I've not been in government for 4 years now. I am perplexed by it because we had an app that worked pretty efficiently during COVID. But I'm also not technically well equipped to understand whether or not what was there before could be adapted into what we now need. So I don't know the answer to that. I do think an NHS app is important. I think we need to be careful with that because not everyone in our country, not all of our fellow citizens can access the kind of technology that the app would operate on. So we need to be careful to not exclude sections of our community. In 10 years, perhaps less, everyone will be able to access that, 10, 20 years. But right now, that's not the case. I think about my own relatives. It would be neither use nor ornament to them. But that's not to say we shouldn't have one. I don't know why we don't. And I would hope that the Scottish Government would make quick strides to ensure that we have an app that genuinely, not for gimmicky reasons, not to do super clever things that we don't need it to do, but genuinely provides patients with a level of information that is appropriate for them, that is secure, and that helps to increase accessibility to healthcare.
Okay, well, I'm going to take some points from the audience now. I think you'll be pleased to hear that Richard Simpson is sort of fanboying over you in the comments, seems to be agreeing with you've given him faith again that we might actually get some of this stuff done. Richard, you mentioned that there's a point you make about productivity in the NHS. Do you want to come to us and ask that question of Jeane?
Jeane, welcome. And I do think a lot of what you've been saying is common sense, and it is a pity that health remains a political football, but I'm afraid that probably is inevitable, certainly for the next year. But I do agree with your point about planning now for a cross-party, all-party agreement on how we progress. And I was particularly pleased that you agree that the number of health boards now is at 14, duplicating and replicating things like who can use what drugs approved by the Medicine Consortium is completely ridiculous. But the one major concern I have, I've got a lot of concerns, but one of the major concerns I have is about productivity. Mm-hmm. It has not yet returned to the level of 2019, despite the fact that we've actually increased the number of staff, particularly in hospitals, not in the community, but in the hospitals. The productivity is low. And in some of the recent discussions I've been having with people who are not many in number in Scotland, not like England, but people who work both in the health service and the private sector, do a certain amount, they tell me that the productivity, that is the number of operations they do in a day in the private sector, is massively higher than what they can achieve in the public sector. One recent pediatric cardiological surgeon said that he can do 5 operations in the private sector when he can only do 2 in the same time in the public sector. So have you any thoughts on productivity?
Thanks very much, Richard. Yes, I do. The one slight caveat I'd make to what you've said is, of course, as you know, what the private sector deals with are the less complex and complicated cases, whereas our health service is dealing with all cases.
Yeah,
however,
yeah.
I do think, I think you will find actually a higher than 5 operations a day in some of our hospitals in cardiology. But I think one of the examples I would give of why 14 territorial boards is not the most efficient way to structure and organise our health service is the booking system for elective operations. So I'm not talking about emergency here, I'm talking about elective. So some of those will be heart procedures, some will be orthopaedic as people understand it. My own view is that we could easily have a regional booking system that, in fact, I know that such a thing was devised, but has not been implemented. A regional booking system that takes all the hospitals in, for example, the west of Scotland. So Greater Glasgow and Clyde Health Board, Ayrshire and Arran, Forth Valley, and all the hospitals that, for example, have the capacity to undertake hip and knee operations. And then offers, so you look at that as a whole. You've got all of those theatres. You can designate some of those theatres as available for emergency work, because that is often what throws out elective work. But you don't need them all for emergency work. And you can then genuinely offer what patients currently have at the minute, but don't always know that they have, the option of choosing to go further away from their home for the knee operation or the hip operation or the cataract operation, because the waiting time is shorter, or to come closer to home because even though the waiting time is longer. But a regional booking system, 3 regions in Scotland perhaps, would improve the use of our theatre capacity across the country.
I completely agree with you, and I think separating elective and acute as far as possible is an element of that, which is really important. And of course, the new hubs are doing a bit of that, which is important. I think the other thing that's unique to Scotland, where we have a very publicly run service, I mean, the involvement of the private sector is only as a sort of an emergency, when we can't get the capacity in the health service itself. And all the parties have agreed on that, by the way, which is unusual. But the separation is important. But we've also got managed care networks, and they, I think, are something that we haven't trumpeted about and haven't developed to the extent that we might have. I would make that compulsory for all boards where you have a regional service, as the one I went to, which was for my esophageal cancer. I had the operation at the Glasgow Royal, but I was treated at the Beechton and I was treated at Forth Valley, Larbert. But it was a combined system that had better outcomes, fewer side effects than the individual hospitals all trying to do it on their own. And I think where the mass is not huge, having these MCNs would improve the productivity, along with separation of acute and elective, which means you don't have to cancel elective procedures, sometimes with the person actually already in the bed. which is a disaster. Chris, could I ask one more question? Or
Yes. If it's short, try and keep it short so we do get some more people.
Delayed discharges have been a perennial problem despite attempts and promises. But one of the factors that struck me is that in England, there are 55,000 patients funded by the NHS in care home beds. And in Scotland in 2015, after the report by a geriatrician, who I don't think knew anything about it, we abandoned that. We stopped all NHS funding in care homes. Surely if there's any spare capacity in care homes and they can take people who would otherwise be a delayed discharge, we should be going back to using that so that we can clear the delayed discharges. Because as you know, it's a whole system problem of admission, delayed ambulances, then delay in A&E because the beds are not empty because there are delayed discharges.
I'm not entirely sure, Richard, that it is the case that we don't have, we don't make use of residential care as, if you like, a step-down facility between acute care and the home, the individual's own home. I'm not entirely sure that we don't make use of that. We certainly did make use of that during my time. It does help the acute sector. There's no question about that. And that flow through that you talk about that it ends up in the absence of which means that you've got the backup at A&E, which is precisely the place where you do not want a backup with emergency care. But I'm not sure in and of itself that actually resolves the problem. I think what we need to do is better resource social care so that people can more quickly go to their own home. So, for example, now, I don't believe this is done everywhere. This is part of our problem with 14 territorial boards, 32 local authorities. But one of the approaches that does work is that as soon as a person is admitted to hospital, where their discharge, because of what they're admitted for, is likely to require some level of social care support, albeit short-term, on their discharge, that the planning for that begins at the point of admission, rather than at the point when they're getting ready to be discharged. And that works really well, because as you have the operation for the fractured femur or whatever it might be, as you recover from that, the plans are in place for the social care support that you will need in order to safely go home. So there are a number of things that can be done to improve the system of delayed discharge. I think part of the difficulty is that too often we have to almost negotiate that 14 times or 32 times, which seems, in a country of just over 5 million, a rather superfluous effort and a waste of time.
Thank you, Jeane. June Deasy, you've got a question about physical and mental health, if you'd like to come on and ask that.
Yeah, thank you. I'm with the British Psychological Society, and in our manifesto for the Parliament elections in 26, we've called for more genuine parity of esteem between mental and physical health, because obviously it's been a long-standing government commitment, but the reality is that there's still a massive gap really between physical and mental health provision. And I just wondered what your views were in that, like why that continues to be the case and how could we better narrow that gap. And as a plug for our manifesto, we do have a range of recommendations and suggestions for how that might be achieved.
Thanks very much, Jeane. June, good to speak to you. I'd be interested actually in reading your recommendations, because I think whilst the commitment from government, from political parties is a genuine one, I think what politicians always need are evidenced recommendations from people who are either professional in the field concerned or experience the conditions that are being talked about. So I think it would be interesting to see your manifesto. I think why is it still the case? I think it's still the case probably for two reasons. Partly there remains a degree of stigma around the whole issue of mental health. It's yes, it's improved, but it's still there. Sometimes in an individual's own mind, so that means they are reluctant to come forward and say that they have mental health issues. It can be seen wrongly as a form of weakness, in a way that a broken leg is never seen as a form of weakness, even if it was something daft that you did yourself that then broke it. And I also think the other difficulty is that it is not seen. So if I have a physical problem, that is often visible. And it's a bit like disabilities, where people feel unseen because their disability is not immediately obvious. So, those are about attitudinal changes in society. You just have to keep going. But actually, if you take practical steps to improve parity of esteem between physical and mental health, you do begin to change attitudes. So I think your manifesto and your recommendations and those from other bodies like yourself will be really important in 26. And please demand that politicians pay attention to them.
Yeah, thank you. And just one of our main points as well is the fact that they're so interrelated. So with delayed discharge, for example, having psychological services involved when the patients are still before they're discharged, then it reduces the risk of readmission further down the line. They're better prepared. So there's a lot of really good case studies as well that we've got. So basically how psychology services can really help with address a range of current challenges.
I think that's absolutely right, actually. And one of the examples that sticks in my mind is the involvement of psychological services with patients who have heart conditions. Anything from heart transplant patients through to patients who may be older, who have heart attacks or strokes, where the recognition that there is a psychological impact to that condition that will remain if it is ignored, even when the physical condition is significantly improved, is really important, because it helps the individual significantly and their family, but it also prevents further problems down the line.
Okay, thank you for that. Kate Hogarth, you had a question about unpaid carers. Would you like to ask Jeane that?
Yeah, thank you. I'm from Shared Care Scotland. We're one of the national carer organisations. My question is around the right to a break from caring that was recommended as part of the Feely review. It came through from unpaid carers that this was a really vitally important part of carer support, and has since been passed as part of the care reform bill. But a recent survey that we did said 96% of carers said that they always, sometimes, or often need a break from caring, but only 7% are actually able to access it. With some of the issues that are being discussed today about hospital discharge and people getting cared for at home, it potentially places more of a responsibility on carers who are already stretched to their absolute limits. And our concern as an organisation is that you can give carers the right to a break, but if there isn't this infrastructure to deliver the variety and capacity of support that they need, the right itself is meaningless. So my question is, how can we positively influence the development of a right to break when the rhetoric seems to be that there's not enough money, there's not enough capacity, and there's not enough resource within the system?
So I'll tell you what, Kate, what came straight into my head as you said all of that is an answer to your question: cause bother. Lobby politicians, try and get yourself covered in the media if you can. Make the case. Now, hospital at home does not increase necessarily, or even at all, the burden on unpaid carers. Some work was done in the creation of Social Security Scotland to recognise that to a degree. But you're right, there is no point in having rights if they cannot be delivered. And so you have a parliament that voted for that legislation. And I think they need now to be lobbied and argued with and pushed to put in place the resources that can deliver it, even if that delivery is phased over a number of years to recognise legitimate financial constraints. It is perfectly reasonable for unpaid carers to see what the plan is that will allow that right to be met.
Okay, and we'll probably get time for one more question, I think, just before 2 o'clock. And Gillian Mathewson, you've got a point about people living with the long-term impacts of COVID.
Mm-hmm.
Gillian?
Yeah, sorry, just trying to get my
All right.
my thing off mute. Yeah, so I am a carer for my child has a neurological form of long COVID. And you spoke earlier about the response through the pandemic and how, you know, that kind of iterative approach of when they're solving, you know, the next challenge came up, solve the challenge and so on. And it feels very much like that has now stopped. And so it's, you know, you've got all these people with long COVID and you know, there's ME. So I actually represent a charity called Pans Pandas, and that's a pediatric autoimmune response. And my child developed that as a result of COVID. And it's that thing of, you know, you've got, in particular, I suppose, with long COVID and kind of associated issues, they're trying to get support in a really crowded health space already. And I think that I find is a particular challenge because, you know, you might be sort of a much smaller organization, and trying to get that kind of voice heard in those situations. And I will say, so as part of what you were saying earlier as well about you know, going private, almost everyone I know with similar challenges as our family have had to go private, not out of choice, but out of necessity because they are not supported on the NHS. And I suppose what I really wanted to know is what your thoughts are on that.
So thanks very much, Gillian. I can't give you a comprehensive response to that because I don't know what work has been undertaken in the last few years to provide an increased understanding of the various elements of what's described as long COVID and what the resources are needed to respond to that. I do know that the understanding in the period before I left office of what was involved with long COVID was a developing understanding in the range of, I mean, I remember initially it was considered that it would be seen most in heart conditions, for example. Now, whilst that remains true, I believe, it is much wider than that and has many other impacts on people. So I really am sorry that I can't answer your question. I think that it would be important for the health service and therefore for government in overseeing that health service to understand the various elements and the demographics of long COVID, and to see if more work can be done. I know that some work was begun with the Chest, Heart and Stroke organisation about the services that they could offer and the additional resources they would need to provide that. But I suspect from hearing what you've had to say that it is wider than that and affects other aspects of people's physical and psychological life. And so I think there needs to be perhaps a degree of combining of all the different organisations. I have actually heard of yours. although I don't know, to my regret, I don't know a great deal about it, but I have heard of it, a combining of organisations working with people who are suffering from long COVID to combine their strength, if you like, in order to start pushing government and the NHS to provide a more comprehensive service and a route of access. I think that is often the problem for people here, but in other fields as well, is where do I start trying to get the help that I need? And it is often unfair on our GPs, for example, because, you know, that is our first point of contact. And if they don't have that information, then they feel that they can't help, and they feel that somehow that they're not doing the job that they want to do. So it is about what are the services that are needed, but equally important, what is the route in for me to access those services for myself or for a loved one.
Brilliant. Thank you very much.
Thank you for that, Jeane. Thank you for such a frank, thoughtful and intelligent discussion this afternoon. I think it's quite easy for everyone to see why you're one of the most widely respected health secretaries of the devolution era. So you don't want to come back, do you? You've done your share.
If I could just do health, Chris, and none of the politics, I'd be a happy woman.
Well, just before we wrap up, I just want to let people know that Enlighten is hosting a full-day conference on the future of health on October the 27th in partnership with Chest, Heart and Stroke Scotland and the Royal College of Physicians, Edinburgh. If you're interested in attending, you can sign up via our website. And with that, thank you everyone for attending, for your really intelligent questions. And once again, thank you to you, Jeane.
Thank you very much. And thank you, everyone.
Thank you.